In a healthy heart, electrical impulses spread with strict uniformity. A normal sinus rhythm is a predictable, highly synchronized cascade of cellular depolarizations, driving every single heartbeat. But in ventricular tachycardia, that synchronization collapses. Ectopic pacemakers fire at dangerously high frequencies, overriding the normal rhythm and stripping the heart of its ability to pump blood effectively. A primary pharmacological response to this crisis is the administration of von Willems Class I antiarrhythmics. These drugs are defined by their ability to block fast, voltage-gated sodium channels. This introduces a physiological paradox. Normal cardiac action potentials rely on those exact same sodium channels to initiate contraction. Systemically flooding the bloodstream with a sodium channel blocker should theoretically depress all cardiac conduction, causing immediate cardiac arrest. Yet patients survive the infusion. The resolution lies in a mechanism called use-dependent blockade. These drugs do not treat all cardiac tissue equally. Their therapeutic efficacy is governed by microscopic dissociation kinetics. To predict the macroscopic changes seen on a clinical ECG, we must first analyze the physical state of the individual receptor. Moving down to the cellular membrane, we can isolate a single voltage-gated sodium channel embedded in a myocardial cell. This diagram illustrates the three distinct conformational states a sodium channel cycles through. During phase 4 diastole, the channel is in the rested state. In this conformation, Class I drugs have extremely low binding affinity for the receptor. As the cell depolarizes in phase 0, the channel transitions to the activated state. The pore opens, and the drug's binding affinity increases dramatically. Following the initial sodium influx, the channel enters the inactivated state, which also possesses high affinity for the blocking agent. This differential binding is known as state dependence. Class I antiarrhythmics preferentially bind to channels that are in the activated and inactivated conformations, effectively targeting structures that are actively in use. Because a high-frequency tachycardia forces cells to depolarize rapidly, the local sodium channels spend significantly more time cycling through these high-affinity states. This allows the drug block to accumulate rapidly compared to the slower cycle of a normal resting heart rate. There is also an ischemic exception. Damaged tissue loses its resting membrane potential, remaining partially depolarized. This traps its sodium channels in the inactivated state. This graph demonstrates the result. Successive depolarizations in these damaged or rapidly firing cells cause a progressive reduction in inward sodium current, shutting down rogue tissue while sparing healthy cells. State dependence is the mechanism that allows a systemic drug to selectively suppress ischemic or rapidly firing tissue. Within Class I, drugs are further categorized based on their dissociation rate, how quickly the molecule detaches from the receptor during the rested state of phase 4. This chart graphs a standard ventricular action potential. Notice the steep upward slope of phase 0, representing the rapid influx of sodium. Class 1b drugs like lidocaine are rapid dissociators. They bind during phase 0, but detach almost instantaneously during diastole. Because lidocaine dissociates so quickly, it has virtually zero effect on the phase 0 slope in healthy tissue firing at a normal rate. Conversely, Class 1c drugs, such as flecainide, are slow dissociators. Once they bind to the sodium channel, they remain attached throughout the cardiac cycle. This persistent blockade results in a marked depression of the phase 0 slope, slowing conduction velocity regardless of heart rate. Class IA drugs, like quinidine, are intermediate dissociators. They depress the phase 0 slope more than lidocaine, but less severely than flecainide. Class IA agents also block potassium channels. This delays phase 3 repolarization, lengthening the overall duration of the action potential. These three subclasses, IA, IB, and IC, are mathematical reflections of molecular dissociation speeds altering the action potential curve. These cellular modifications determine the macroscopic electrical readouts a clinician evaluates on a standard 12-lead ECG. The speed of phase 0 depolarization dictates the conduction velocity through the ventricles. On an ECG, this corresponds exactly to the width of the QRS complex. A Class IC drug's depression of phase 0 directly translates into a markedly widened QRS duration. Further down the curve, the timing of phase 3 repolarization determines the end of the T-wave, dictating the length of the QT interval. For a Class IA drug, the moderate phase 0 depression slightly widens the QRS, while its potassium-blocking properties delay phase 3, which significantly prolongs the QT interval. With a Class IB drug, the normal phase 0 leaves the QRS unchanged. However, its unique kinetics actually accelerate phase 3 repolarization slightly, resulting in a shortened QT interval. An ECG tracing provides a direct, real-time readout of these molecular receptor kinetics in action. This matrix consolidates these theoretical mechanisms into a single clinical framework. Class IB agents have rapid dissociation rates. This makes them highly specific to continuously depolarized ischemic tissues, effectively ignoring healthy tissue and leaving the baseline QRS intact. Class IC drugs are slow dissociators. They heavily depress conduction across all tissues, consistently generating a wide QRS complex. Class IA operates as the intermediate agent, combining moderate sodium block with potassium channel blockade, distinctively marked by a prolonged QT interval. Systemic sodium blockers do not induce total cardiac arrest, precisely because their action relies on these kinetic, use-dependent properties. By mapping the microscopic behavior of the sodium channel, the clinical response to a Class I drug becomes a predictable outcome of receptor kinetics.